Once the safety questionnaire has been completed and the patient is safe to have an MRI scan, ask them to change into a hospital gown with the opening at the front. Position the patient head first supine on the MRI table. If necessary, shave hair from the chest area before the patient enters the scanner room, so that the electrocardiogram or ECG electrodes will stick to the skin properly. Prepare the skin using an abrasive gel. Now place the MRI-compatible ECG electrodes according to the manufacturer's guidelines. Connect the ECG receiver module to the electrodes. This is how to place and connect the electrodes in a Siemens Solar scanner. Check the quality of the ECG signal in the integrated display on the scanner terminal. If the signal isn't satisfactory and consistent, then reposition the electrodes. Now close the patient's gown and place the body coil with a spacer cushion over the chest. Secure the coil using a strap and connect the pressure injector to the IV cannula. Give the patient an emergency buzzer, ensuring that they understand when and how to use it. Provide ear protection, including headphones and earplugs in accordance with manufacturer's guidelines. Slowly move the patient into the bore of the magnet and center the laser beam localizer over the mid-chest. Next, move the patient fully into the magnet. Ensure they're calm and comfortable before leaving the room. Once back in the control room, find the patient's name in the browser, or register their details manually. The correct weight and height should be entered so that the specific absorption rate can be calculated accurately. Register the patient as head first and supine. Select the correct protocol according to your hospital and radiologist guidelines. Begin with the 3-plane T2 localizer. It's very important to obtain good localizer images, so if necessary, replan and repeat. Now isocenter to the heart so as to avoid shimming-related artifacts. In this protocol, the first image is a T2 gradient echo axial. Plan the axial scan on the coronal localizer. Place the position block straight across the chest. Use enough slices to cover the heart from aortic arch to apex. Now check the planning block in the other 2 planes and apply. Wait for the axial images to be acquired before planning the 2-chamber localizer. On the axial image, find the left ventricular apex and the mitral valve. Angle the positioning block parallel to a line running straight through the middle of the mitral valve and the left ventricular apex. In the sagittal plane, choose an angle parallel to the interventricular septum. Check that the coils are turned on and then apply. This single-slice T2 localizer scan is performed using an expiration breath hold. Plan the short axis localizer on the two-chamber view and the axial images. On the two-chamber view, place the positioning block parallel to the mitral valve. Angle the positioning block perpendicular to the interventricular septum. If the manufacturer has got a perpendicular function in the planning tab, you can use this for easy planning. Check that the coils are turned on and then apply. This short axis T2 localizer scan is performed using an expiration breath hold. Next, plan the four-chamber localizer using the two-chamber and short axis localizers. On the two-chamber localizer, plan the position block parallel to a line running through the centre of the mitral valve and the left ventricular apex. While planning on the short axis localizer, care should be taken that the planning block does not overlap the aorta. On the short axis localizer, plan the positioning block parallel to the line along the right ventricular apex and the left anterolateral papillary muscle. This four-chamber T2 localizer scan is performed with an expiration breath hold. Here you can see a clear four-chamber view. Now we can start the Cine imaging. On the four-chamber localizer, place the positioning block parallel to the line through the centre of the mitral valve and the left ventricular apex. Check the position block in the short axis localizer. Place the block parallel to the interventricular septum, bisecting the left ventricle into two equal halves. And then apply. This two-chamber Cine scan is performed using an expiration breath hold. Next, plan the four-chamber Cine view. If the previous four-chamber localizer gave a good clear view, then you can copy the same planning for the four-chamber Cine. Check your planning on the two-chamber Cine and the short axis localizer and then apply. This four-chamber Cine scan is performed with an expiration breath hold. This three-chamber Cine is planned on the short axis localizer. Check for the short axis slice where the aorta and the left ventricle converge to look like a snowman. Your aim is to bisect the snowman lengthways. To do this, angle the position block parallel to the line through the centre of the aortic valve and the left ventricle. If the manufacturer has a perpendicular function in the planning tab, please use this to achieve more accurate planning. This three-chamber Cine scan is performed under an expiration breath hold. This is the four-chamber view where you can see the left and right ventricle, left and right atrium, the mitral valve and the tricuspid valve. The next view is of the left ventricular outflow tract, or LVOT. Plan the LVOT coronal Cine on the three-chamber Cine. Place the position block parallel to the line through the centre of the aortic valve and the ascending aorta. If the manufacturer has got a perpendicular function in the Planning tab, please use this to achieve more accurate planning. Check that the coils are on and then apply. LVOT coronal cine scan is performed on an expiration breath hold. Now plan the aortic valve axial cine scans on the 3-chamber and LVOT coronal cine views. Plan the position block parallel to the aortic annulus on both the 3-chamber and the LVOT coronal cine. If the manufacturer has a perpendicular function in the Planning tab, again you can use this to achieve more accurate planning. Usually, aortic valve scanning requires 2 to 3 slices to ensure accurate coverage. Next, plan the right ventricular outflow tract, or RVOT cine scan, on the axial localizer. RVOT cine scans can be planned in different ways. In our department, we prefer to use the 3-point planning technique. 3-point planning uses 3 different points in the curved anatomy to achieve an optimal angle. The planning block will automatically align along the 3 different points. Using the 3-point planner, set the first point in the right atrium, the second point in the mid-pulmonary trunk, and the third point at the pulmonary artery bifurcation. The planning block will automatically align parallel to the right ventricular outflow tract. The RVOT shows the pulmonary valve and pulmonary flow. Now we're going to show some morphology scans. Stir imaging is an optional sequence mainly used for the assessment of myocardial edema in pathologies like myocarditis. For stir 4-chamber views, you can simply copy the planning from the 4-chamber cine scans. Check that the coils are on and then apply. Stir 4-chamber scans are performed using an expiration breath hold. For stir 2-chamber scans, just copy the planning from the 2-chamber cine. Check that the coils are on and then apply. Stir 2-chamber scans are performed under an expiration breath hold. For the short axis stir, 3 individual single slice scans are performed. The first is over the apex of the heart, the second at mid-ventricular level, and the third at the base of the ventricles. Angle the position block perpendicular to the interventricular septum. Check the position in the 2-chamber view and place the block perpendicular to the myocardium. Stir short axis scans are performed under an expiration breath hold. We've now completed all the pre-contrast imaging. If use of contrast isn't contraindicated, post-contrast cardiac MRI scans are performed with a double dose of Gadavist. Using a pressure injector, inject the Gadavist followed by normal saline flush. Immediate post-contrast scans are useful for diagnosis of blood clots and tumours. Now plan the immediate post-contrast PSIR 2-chamber scan. In our department, we prefer to do free-breathing PSIR scans due to their superior spatial resolution. For this, you can simply copy the planning of previous 2-chamber scans. Scans can be performed using a breath hold or free-breathing PSIR sequences. PSIR sequences use prospective cardiac gating. When undertaking these scans, it's better to capture the cardiac cycle in order to ensure more accurate gating. Again, you can copy the planning from the previous scans for the 4-chamber and 3-chamber post-contrast scans. Now plan the short-axis Cine scans on the 4-chamber and 2-chamber Cine. Scroll through the images to find the 2-chamber view showing the heart at its maximal expansion. This is the end diastolic view. Plan the position block parallel to the mitral valve, which is perpendicular to the myocardium. Find the 4-chamber end diastolic view and place the block perpendicular to the interventricular septum. Slices must be sufficient to cover the full ventricles, from mitral valve to the left ventricular apex. Check that the coils are on and then apply. Short-axis Cine scans are performed under an expiration breath hold, with 1 slice on every breath hold. Now it's time to plan the TI scout. This is used for identifying the myocardial nulling TI value. If you want to find out more about the TI scout, take a look at our website. The scout can be planned in either 4-chamber, 2-chamber or short-axis view. In our department, we prefer to do it on the short axis. For planning, you can simply copy the image position from the middle slice of a short axis Cine scan. This scout scan is performed under an expiration breath hold. It's now nearly 10 minutes after the injection. This is a good time to perform the delayed PSIR sequences. Check the TI scout for the myocardial nulling TI. That is the TI value where the myocardium appears darkest without any artifacts. In this patient, the appropriate value is 260 milliseconds. Now enter that value into the TI box of the two-chamber delayed PSIR sequence. Copy the planning from the post-contrast two-chamber scan. The two-chamber delayed PSIR sequence can be done on an expiration breath hold using a normal PSIR sequence or with a special PSIR free breathing software option. In our department, we prefer to do it with the free breathing option. This is because of the sequence's superior spatial resolution. Another reason to use free breathing is that patients can get tired towards the end of the scan. They may then struggle to comply with long PSIR breath hold scans. Repeat the same process for the four-chamber delayed scans, copying the planning from the previous four-chamber sequence. Now you can plan the short-axis delayed scans. For the short-axis planning, it's important to copy the slice number and position from the short-axis Cine. Short-axis scans take about 4 to 6 minutes to complete. As the time passes, the TI nulling value of the myocardium increases. Instead of the previously chosen TI value of 260, you should now use the slightly higher value of TI 280 for the short-axis delayed scan. Capture the cardiac cycle for more accurate gating and apply. This is the post-contrast delayed PSIR short-axis scan. Normal myocardium appears dark in these images. There are many types of flow studies for vascular quantitative flow analysis. We'll show you an example of aortic through-plane flow in this tutorial. For other flow measurement techniques and planning, please take a look at our website. For every flow study, it's important to identify the most accurate flow velocity. A velocity scout, Venk scout, with multiple flow velocities ranging from 50 to 300 is used for this purpose. Plan the Venk scout on the three-chamber and LVOT coronal Cine. Plan the position block perpendicular to the ascending aorta right above the sinotubular junction on both the three-chamber and LVOT coronal Cine. Venk scout scans are performed under an expiration breath hold. Now open the flow sequence and copy the planning from the Venk scout. Wait for the Venk scout to complete. Scroll through the flow velocity scans and find the image with the velocity where the ascending aorta is dark and the descending aorta is bright. Choose the velocity from an image with no aliasing artifacts. Use this flow velocity in the phase contrast flow sequence and apply. Phase contrast flow scans are performed under an expiration breath hold. Now we'll turn to some myocardial mapping sequences. Two main types of mapping are T1 and T2. Mapping sequences are all planned in the same way. T1 mapping is done pre and post contrast. We'll show you how to perform a T2 mapping. T2 mapping uses a 3 out of 5 slice planning technique. This technique will ensure the short axis slices are planned properly over the mid-myocardium with an appropriate slice gap. Now plan the short axis mapping scans on the 4-chamber and 2-chamber Cine. On the 2-chamber end diastolic view, plan the position block parallel to the mitral valve and perpendicular to the myocardium. Check the position in the 4-chamber end diastolic view. First, plan slices with an equal slice gap to cover the whole ventricle. Adjust the slice gap if needed. The user can then reduce the slice number to 3, which will remove the slice at the apex and the one at the base. Check that the coils are on and then apply. Short axis mapping scans are performed under an expiration breath hold, with one slice on every breath hold. Please make sure to review all your images before ending your exam.